Pancreatic cancer. So what are the various risk factors? So I've again included this table from your Bailey and Love, which gives you a risk factor for development of pancreatic cancer. It includes your demographic factors, age with the peak incidence being in 65 to 75 years. Then we have male gender, a black ethnicity. Cigarette smoking is considered to be a risk factor in case of your pancreatic carcinoma. Then the various genetic factors and the medical conditions include your family history. Two first degree relatives with pancreatic cancer, the relative risk increases around 18 to 57 fold. Then germline BRCA2 mutations in some high risk families, right? Then hereditary pancreas, which increases your 50 to 70 fold increase risk. Then we have your chronic pancreatitis, which has a 5 to 15 fold increase risk of pancreatic cancer. Then we have Lynch syndrome, ataxia, telangiectasia, Peutz-Jeghers syndrome, familial ovarian breast cancer syndrome, familial atypical multiple mole melanoma, familial adenomatosis polyposis, which increases risk of your ampullary or your duodenal carcinoma, diabetes mellitus and obesity. So please remember the syndromic associations of your pancreatic cancer, which can be asked in your exam. So these are your few important risk factors from your Bailey and Love, which I have taken for your pancreatic cancer. Now regarding the clinical features, if it is a right-sided pancreatic cancer, it is going to present jaundice from your biliary obstruction, right? Then presence with pruritus and epigastric pain, which is radiating to back. Now, if it is a left-sided pancreatic cancer that is more predominant towards your tail, then pain will be your most common presenting feature, right? And jaundice is rare in your left-sided pancreatic cancer. Now, the non-specific symptoms include your anorexia, asthenia and loss of appetite, and your metastatic disease would include your Virchow node, systematic nodule, which is your umbilical nodules, and Bloomer shelf nodules that are found during your digital rectal examination, right? Now, your investigation that we do is your triphasic CECT pancreatic protocol. So first we have your without contrast phase, which is good to see your calcification and edema. Now in case of your early arterial phase, which is in your 10 to 20 seconds, right, we see if there is a good uptake or a poor uptake. A poor uptake would signify your adenocarcinoma, which will have a poor uptake, and a neuroendocrine tumor will have your good uptake. Then we have your late arterial phase, which lasts for 40 to 60 seconds. So we see the enhancement of tumor in relation to the gland, and over here we check for the relation between your SMA and your SMV. SMA is your superior mesenteric artery and SMV is your superior mesenteric vein. Then the venous phase, which occurs after your first 60 seconds, we check for the rest of the parenchyma and we check the splenic vein for any thrombosis and portal vein for any thrombus, right? Now another important concept in your pancreatic carcinoma is your borderline resectable pancreatic carcinoma. So what is your definition of your borderline resectable pancreatic carcinoma? So first we have this venous involvement. So over here what happens is that SMV or portal vein is involved and they're distorted and narrowing, but they have a suitable vein proximal and distal which would help in the reconstruction of this vein during surgery. Then the arterial definition of your borderline resectable. Now when the tumors are located in your head of pancreas, there is abutment of your superior mesenteric artery to less than 180 degree, and there is abutment of hepatic artery but not extending to celiac artery, right? And when it is present in the body and tail, there should be less than 180 degree involvement of your celiac artery. So this is your definition of your borderline resectable pancreatic carcinomas, which is gaining a lot of importance this day. So please do remember regarding it. Now regarding your treatment, so the pancreatic carcinomas could be either resectable, borderline resectable or unresectable. So first let's take a look at your resectable part. So if it is resectable, we proceed for a diagnostic laparoscopy, followed by your Whipple's procedure. Right. So, an important question that is asked you with respect to your Whipple's procedure is, what are your anastomosis done? So, we do a pancreatico jejunostomy, we do a hepatico jejunostomy, and we do a gastro jejunostomy, right. And then we have your borderline resectable, where we do first an endoscopic ultrasound guided biopsy. If it is positive, then we go for a PTBD, which is percutaneous transhepatic biliary drainage, or your ERCP biliary drainage, followed by a newer adjuvant chemotherapy, which would include your drug gemcitabine and carboplatin. Now, following this, we again do a MDCT and check for resectability. Now, if this is resectable, we proceed for surgery, and if it is unresectable, we continue your chemotherapy, right. Now, in this part of your borderline resectable, instead of going for a neoadjuvant chemotherapy, if we want to reconstruct the portal vein or the SMV, or then it can be performed. The reconstruction of the arteries is usually being taken nowadays. So, even if the artery is involved, the reconstruction can be done for the arteries, but it has yet not gained a lot of popularity. But the reconstruction for the portal vein has gained a lot of popularity these days, right. So, if so I'll just mention it over here, like direct surgery with your portal vein reconstruction, right. Now, the last part is your palliation. So, again I have included this table from your Bailey and Law, which has beautifully explained your palliation of pancreatic cancer. So, first, relief of jaundice and treat the biliary sepsis. So, we need to go for a surgical biliary bypass. It is known as your triple bypass. Now, your triple bypass includes your hepatico jejunostomy, then it includes your gastro jejunostomy, and it includes your jejunostomy, right. Then a stent can be placed at ERCP or percutaneous transhepatic cholangiography. Then improving the gastric emptying by your surgical gastroenterostomy and your duodenal stent. Pain relief by stepwise escalation of analgesia and your celiac plexus block, or your transthoracic splanchnicectomy. Then you have your symptom relief and quality of life, encouraging the normal activities, enzyme replacement for steatoria, and treating of diabetes. And then we need to consider your chemotherapy. So, this is your treatment of your pancreatic carcinoma, right. Thank you.